Hi, everybody, and welcome to DEARG, the podcast that will bring you information about endometriosis and adenomyosis. My name is Kathleen King, and I'm joined by a very good friend of mine, Heather Guidone. Heather, I'm not even going to attempt to introduce you because your bio is longer than I have years in my life. So will you give us a brief introduction to yourself and how you got involved in this crazy world of advocacy for endometriosis?
Oh, I will. Thank you for having me, my friend. It is always a pleasure. Thank you for all your lifetime of efforts. I am just happy to stand on the shoulders of your giant. So thank you for that. So again, I am Heather Guidone. I am a board certified patient advocate and also the program director of the Center for Endometriosis Care. Also a person who has lived with endometriosis, adenomyosis, and fibroids and infertility. And I think that's it for now. So I have a lot of lived experience that goes into my work. And then much like yourself, my advocacy journey was born of necessity. I had to advocate for myself along the way. And some of those lessons were pretty hard to learn. And I thought, well, I have to ensure that others don't go through this the way that I have. Unfortunately, we're not always successful, but I do hope that over our lifetime of shared efforts, I do hope that we've helped a few folks along the way.
Absolutely. And I was one of those people back in the very early days who was very fortunate to come across yourself and Nancy at the time. And it changed the path of my life, changed the path of my treatment, and changed so many things. And I think we sort of see that knock-on effect, don't we, where we have one strong advocate teaching another, and then you pass that on down through the generations. God, I'm making us sound like we're very old, but we're not. Like, I'm only 24, so that makes you 26. So
26. I absolutely am nowhere near 30, and certainly not in my 50s, heaven forbid.
Absolutely not. Even though we have 25 and 35 plus years experience, like, yeah, we were children. We were just children.
Babe.
But I think that's one of the things that sort of we see now in, the web 2.0. We've got social media, we've got sharing, we've got Instagram, we've got TikTok, we've got all of these amazing tools at our hands. But one of the gaps, and I'm sure you see it as much as I do, is accurate information. And I'm not saying back in the late 90s and early 2000s, the information was more accurate. But because the community was smaller, we had a better hold on the information, I think, and we were better able to control that. And I think that's one of the challenges of advocacy at the moment. And have you any tips maybe for some of the advocates that are up and coming out there at the moment and listening in today? How do you keep your information accurate? How do you make sure that we're on top of the best information out there, and to make sure that we fact check ourselves?
Oh, absolutely. And it is difficult. And I think you make a very salient point. In the olden days, even before the socials, even before, the web was so predominantly featured in endometriosis and other disease education, I've told this story a million times. What did we have? We had one association. It was pen pals, right? And I think that they really set the precedent, to give them credit, in the way that they disseminated the information. It was journal articles, it was evidence-based literature, it was newsletters that were distilling down the information so that anybody at any level of health literacy could understand it. And I think that that's very, very important, and we need to see more of that today. Obviously, of course, what we thought we knew back then in the late 80s and 90s, what we thought we knew then, of course people evolve. Our understanding of the disease evolves. Our understanding of treatments evolve. Our understanding of pathogenesis hasn't much evolved, but we're expanding it. All of those things and all of those factors surrounding the disease. Obviously, with time comes knowledge. When we know better, we do better. So it is very important to sort of look at that original construct and that concept that was set forth by the first association. How did they do it? Well, they disseminated it. They made sure that it was easily understood, that it was very facile information that anybody at any literacy level could understand. And really, you have to have a sense of reasoning. I tell people all the time, believe nothing, even if if I've told you. Research it for yourself. Not everybody has the capability to either access, so much as behind a paywall, or even understand a lot of the evidence-based literature. So we really depend on the peer setting, right? And that's where the socials have been so important. I mean, you remember that first women's health / endo group, right? That's where we all kind of convened. What was it, 50 of us on the first electronic platform? We thought this was the greatest thing since sliced bread. I think today it would probably look, like a jalopy. But that's sort of where we came together. And you're right, we did have a better control, not in the sense that we were trying to gatekeep by any means, but a better and easier time of more quickly disseminating the message. If an article came out, we were able to get the word out. If an article was incorrect, we were able to get it corrected in a much, much easier way now. They say, a lie gets around the world before the truth gets out of bed. And I think that's true with endometriosis information as well. And unfortunately, we live in the era of influencers. Anybody with a phone can become an influencer. You can go on TikTok. Well, I can't go on TikTok unless there's a cat video, but you can go on TikTok. You can go on Instagram. Anybody can say anything they want, and there are no repercussions. So I think it's very, very important that you surround yourself and you insulate yourself really with fact-based sites. I say this all the time. Endo Girls blog, Kate has an incredible ability to take very, very complex literature and research articles and studies and distill it down to a couple of simple lines. Folks like that, folks like you, I mean, your work speaks for itself for decades. Follow people like you, follow the associations and the organizations. Most of them are doing a pretty good job. Some of them are not. That's just the facts. But you follow the folks that are sharing the information and ask yourself, is this timely? Does this seem relevant? How does this fit into my life? Is this something that I should or could be pursuing? Does this sound like this makes sense? And at the end of the day, really, you have to kind of think to yourself, where's the origin of this? If it's a study, for example, are they simply transplanting native endometrium, or are they studying the actual lesion? And I think it's really important, although unpopular to say, I think it's really important to look at who the sponsor is. Was this written in the service of an industry sponsor, or was this written in a patient-directed research setting where patients have co-created the study? Things like that all matter. But again, at the end of the day, if something doesn't sit right with you or doesn't feel right, it's probably not right. So do your homework. There's a journalistic principle where you have to fact check and collaborate, and then collaborate that collaboration. Do that. If more than one person is saying it, maybe there's some substance to it. If they are charging you $6,000 for your coaching program to access the information, maybe that's something else. But it's totally up to you. If you want to pursue that route, do that, but do it in a way that's informed so that you know that you're getting the best information possible and you're making the right decisions for yourself, whatever that looks like to you, whether it's surgery or cannabis or acupuncture or all of the above. It has to sit right with you.
Absolutely. And it is one of those things, isn't it? Because endometriosis, and even we'll throw adenomyosis in there as well, are such individual diseases. We all have to do that pick and mix. We all have to take that 1% to get us that bit of benefit or that bit of relief. And for different people, that looks like different things.
Absolutely.
And this is one of the things that, my biggest bugbear is misinformation. My second one is not including patients in research. And we've seen the absolute, insert expletive here, papers that have come out where we've been described, our physical and sexual attributes have been described, how tight clothing influences, how tight clothing influences endometriosis. It's crazy. And you can see where patients were left out of that. But I think that's one of the things that certainly has come through in the last few years, is that we now recognize that patients and patient advocates and their friends, family, supporters can play a huge role in this. And that's massive. And I think that's the potential to change, isn't it? And, we have so many scientists within the community, like Kate, breaking down the information, delivering it across to people. That makes a huge difference. It really, really does.
It really does. And I think anytime
Massive.
that you have what they call now, quote unquote, it has to be patients included, you will even see some sites that require that. As you
Mhm.
submit your paper, that's one of the questions that you must check off. What patients, where, when, and how were they included in the formation of this study? So we're definitely seeing a growing shift towards that, and rightly so. Patients are not the objects of research. They are not the objects of change. They are the drivers. And if you're not including a diverse population, if you're not considering, different ethnicities, different genders, different things into your research and creating it in a way that suits the target subject audience, what are you doing? You're leaving out so many voices and such incredible information that really could be so transformative to so many patients. So I'm pleased to see it. We need a lot more of it. A lot more.
Absolutely. And it needs not to be a checkbox exercise, because I've seen plenty of that myself, and I'm sure you've seen it. Where have you included patients? Yes, we
Yeah.
have.
Not
We put their name
performative,
on a form.
right, but
You
in a
know,
substantive, real, tangible way where we sat around a round table and we said, what does this look like for you? Because lived experience, in my opinion, trumps all else. Period. End of story.
absolutely, 100%. And it's, I think through that lived experience, then, and we bring in our own backgrounds, no matter what that is, from a work or a volunteer or even a family and life experience, you can throw it all into the mix because it's all relevant. But if we still kept looking at the same things over and over again, we're still looking at this as a middle class white women's disease.
Bingo.
We're way bang on back to the 80s, and there's not really much we could go back to for that apart from the hair. But aside from that, some of the music as well too, actually. But no, we can ditch we can ditch all the endometriosis stuff from then. But
Leave that there for sure. No, you're absolutely right. I mean, there's definitely something to be said that there is a strong holdover for that affluent white women. And the implications of that in terms of making certain segments of our patient population that much more vulnerable, that much more, I don't want to say victimized, but certainly we have worse outcomes, less access to care. That's just compounding the problem. And the diversity and justice and equity spaces need to be filled with activism to ensure that this stops happening.
Yep. And we have to reach the hand out. There's no doubt about it, and help everybody along the way in this journey, because
Mhm.
it can be very isolating. It can be very frustrating. And at times at 3 a.m, when you're staring down, into the bottom of the medication box again, you can feel very much alone. And that should not be the case in this day and age. I think there's enough of us in the world. There's enough of a connection out there. Nobody should feel alone with this disease.
Absolutely.
And I think we do have to continue to fight that a wee bit harder. And, when we talked a wee bit before about, and you've given some talks for me in Ireland around endometriosis at some events, and that's been really, really good. And you've brought in the other part of your life into this, which is the Centre for Endometriosis Care and your work there. And, it's one of those places where so many patients aspire to travel to. And if we could clone, Dr. Sinerva, we would take him over here in the morning and give him a clinic. But from a practical point of view, we know some patients are very fortunate in a very privileged position and can, travel to the centre and maybe travel to other centres of expertise throughout Europe. But from a practical point of view, when it comes to equity and to getting patients their treatment, as a surgical director in the clinic that you are in, how do you see that working for patients? Can you see a time where we may have more surgeons or more accessible treatment?
Well, that's a really important thing. It's not just having professionals like us who work in healthcare, like yourself, like people like Kate who are scientists. It's not enough just to have us out there. And there's not enough of us either. You need to bring everybody to the table, as you said earlier, caregivers, researchers, scientists, legislators, all of them. But a very integral component of that are the Dr. Cernovos of the world. You know, he works very, very hard to leave a legacy. And what I mean by that is training others. Because certainly, as much as I wish we could clone him and Dr. Eugenio Colon, unfortunately, I have not mastered this art yet. So what they do is they teach others. We run a fellowship. They lecture abroad. You know, they go internationally. They teach internationally. They publish. They do whatever they can. Really, yes, to spread the gospel, but also to drive home the point of multidisciplinary, interdisciplinary, integrative care, and to teach those skills. You know, all surgeons are not created equal. All surgery is not right for every patient. So there's a lot of nuances. I know that the internet and social media makes it look very black and white. We work in a gray area. And within that area are so many nuances and so many different constructs, because you're not treating a lesion, you're treating a human being. So it's very, very important that you take that knowledge and you pass it on to others. So while I wish that we could put up a center in every state and every country, that's just not something that's feasible. Unfortunately, because of the long-standing institutional barriers to care, we certainly can't get 200 million people through our doors. I would love that. Wouldn't that be amazing? But we can't. So we need to meet people where they are. We need to help them connect to care where they are, how they can, and what that looks like for them. Maybe it's not surgery. Maybe it's PT. Maybe it's acupuncture. Maybe it's all of the above. Maybe it's pain management. You know, we need to be able to spread the education, spread the word about that, that look, you know, there's not one size fits all, but here's what we know has worked so far for a lot of people. And by teaching others, you can slowly but surely start to see those centers cropping up in Europe, starting to crop up, you know, in the Southern Hemisphere. I know Dr. Eugenio Colon has been so critical in establishing a presence in the Dominican Republic. I mean, we're talking about some populations, particularly in the islands, where it's a choice between putting food on the table and a roof over their head or getting endometriosis care. And if they do have the good fortune to get endometriosis care, where are they going to get it? They have to leave their country. So there's still a huge insurmountable problem in that regard. We have fought this together in the trenches with others for decades. I've not seen much change, unfortunately, despite our best efforts. So you've got to leave that lasting legacy. And that's one of the things that's very, very important to him. And that's, you know, something that he works very hard at doing. And I know that others are doing it as well. I mean, look, you know, we've got those surgical conferences, we've got the Endo Summit, we've got those different events where folks are coming together. And again, like Endo Summit, patients are included. So it's really leveling the playing field. But something you said earlier too, which, you know, kind of struck a chord with me because I talk about this a lot too, is the redundancy in research. We've got to stop doing the same thing. A lot of repurposing of old meds, a lot of, you know, the tissue studies versus the actual endometriosis lesion. A lot of that is still continuing, and that's where the money's going. So we've got this incredibly competitive space for research where there could be some amazing high risk, high reward studies coming forth. They're not getting funded because that space is so competitive and so underfunded. So it really does take a village. It's people like Dr. Cernovo training others. It's researchers getting the right money in the right hands. You know, it's legislators like we have here with Representative Jillian Gilchrist, who was instrumental in authoring and getting bipartisan support for a bio research firm. All of those things matter, and they are intersectional. So it's not just get another surgery center created. It's really about get a quality treatment center created and have that research to back it up. Oh, and also we need the resources to support the patients through the journey. So, you know, in my utopia, there would be one in every block. But until we get there, we have to do the best we can to help meet people where they are.
That's it. And that's the big difficulty I think we face here in Ireland is that we have such limited resources in terms of surgical expertise. We have limited resources in terms of the extended services around that. So be it pelvic physios, be it psychological support, be it dietary support, be it whatever. And as you know, we're exporting a huge amount of patients. We have a lot of patients leaving the country for treatment.
Sure.
And again, only this week I've had contact with somebody who has said that they are considering looking at remortgaging to try and get surgery because they're in such a state, they can't work, they can't live, they can't survive, they can't function. But yet this is going to put them into a debt where, again, you know, you have to prioritize health over food, health over your children, health over your you know, paying your mortgage basically. And that's not where we should be.
No.
I think, you know, 25 plus years for me into this journey, I didn't think things would change quickly, but I didn't think that they would be this slow. I didn't think in 2023, where we have changed the abortion care in Ireland, where we've changed, you know, a lot of things in this country. Now, women's health is still at the absolute bottom floor, basement level of healthcare.
Complete bottom. And it's a very, very sad testament, you know, because I like to think coming, you know, from the USA, we're supposed to be this really progressive country that looks out for its citizens and so forth. But again, if you look at the research, if you look at the funding, if you look at the support, women's health, and I say women to include anyone who identifies as female, bottom of the barrel, bottom of the barrel. You know, the fact that we're still taking out loans to get access to care horrifies me.
It is. It's shocking. And, you know, when we take into that, like, and again, you've brought up a very good topic there, like in describing women's health, like we're taking the broader sort of feel on that as well too. You start taking into minority groups within women's health and the extended within the trans community or within communities that, you know, are more marginalized in society as well. We have the, you know, the traveling community in Ireland, you know, we have our LGBTQIA plus community, we have our trans community, and they're all feeling isolations in different ways as well too, on top of this. So we're just compounding all these problems, you know. I do think we have to work harder on this one.
That's really, at the end of the day, that's what it boils down to. It's really a trauma, you know, that is being visited on them. And we know that we have the data. What gets measured gets done, right? But it's not getting done. We have the data that shows you know, the Black maternal crisis, for example. We know specific to endometriosis, we know in the BIPOC community, they have less access to care and worse outcomes with higher complications. In the indigenous population, even when they do have access to good quality care, their outcomes are not as good as pure population. So it's all of those things. And you know, like you said, I didn't think it would happen overnight, but I didn't think that it would be status quo all these years later. You know, and some days it feels very hopeless. You know, I sit on Capitol Hill across from legislators who are in a position to make a difference, or with insurance and payer corporations who are in a position to make a difference. And I plead with them, you know, and I tell them our patients' stories, and I tell them what's going on in endometriosis, and we get a lot of lip service. But we're starting to see a little bit of a shift, right? I mean, what we allow is what continues. Patients aren't allowing this anymore. They're just not. You know, more and more, anytime we do a peer-to-peer or we do an appeal to try to get our patients, you know, extended coverage or increased coverage, we're starting to see a little bit more success in that regard. But the problem really stems from the fact that endometriosis is still viewed as a period disease, right? That it's still viewed as something equivocal in terms of who can treat it, how and when. The subspecialty is not recognized, as you would see with oncology or urology or endocrinology or any of those subspecialties. We don't have that. You know, it took them 10 years just to bump up the codes in terms of describing where the disease is in the body. So all of these things are, you know, really part and parcel of the Sisyphean effort where we're just pushing that rock up the hill every day. And I know that folks want an easy fix. Nobody wants it more than you and I, right? And the other long-term advos. But, you know, we're trying. And the more people who join the battle, the better.
And I think that's the bits that people don't see as well with advocacy. I spoke to a colleague of mine here, Orla, a number of weeks back, and we had this very sort of similar discussion that people don't see the behind the scenes work. They don't see the chipping away constantly, trying to get things like insurance codes changed, trying to get government to have a look at something like this. And there's always a flurry of activity around certain things like Endo Awareness Month. And that's great and that's very good, but we're forgotten about then for the other 11 months of the year.
Right.
But when you rally people up, and we've had it a few times where, you know, Irish patients have written to their TDs, they've written to the government, they've written to their ministers, they've written to their local councillors, and they've laid their story bare.
Yeah.
And it has shocked people. It's scared people. It sort of brings them into a little bit of reality. And I've just listened to a snippet from a radio broadcast today where they were shocked that women were self-diagnosing from listening to a piece on the radio. And like, I'm going, no, hang on, we've been doing this 25 years here. We always have had self-diagnosis after listening to a media article or reading a thing in the paper. And how do you think we all got here? You know, the majority of us learned from somebody else what our disease was. And that certainly has shifted in the last 30 years. So I'm just thinking here, can you tell me what you think has been the biggest change over the last 30 years?
I think patient empowerment, I think taking back bodily autonomy, taking back control and empowerment of their own journey, which is not to say that they're not bumping up against the barriers. People still are. I don't want to in any way trivialize that. They still are, but they're chipping away and going around it much quicker than, say, I would in 1987, 1988. I just didn't know. We don't know what we don't know, right? They're now looking for more timely diagnoses, earlier intervention, whatever that intervention looks like for them, and ways to self-manage and really be in charge, the captain of their own ship, so to speak. That has been very gratifying to see, because it's not that paternalistic care model anymore. It's a really patient-centered model, or should be anyway. It's a very patient-centric model where patients are really saying, this is what I read in the literature. Let's discuss this. They're so educated. They're so literate about their disease. Often they know more than their doctors, right? I think that has been the biggest strides. And with that also comes increased advocacy. Instead of 10 of us sitting in a room now, it's, 500 people on a webinar from every corner of the world. It's people who have zero resources, but they're forming organizations and they're making a difference. All of that has been incredible. And the pushback, I will say the pushback against misinformation and miseducation has been fantastic. We need more of that. There will never be enough of that. Any single given day, we can open up a Google alert or check a journal article and be like, oh, when tissue pieces of the lining of the uterus, painful periods. We can see that anytime. But now people are standing up and saying, no, hold on. Check this resource, check that resource. Please fact check yourself, correct your information, because you're spreading misinformation, which is incredibly harmful. So for me, that has been really gratifying. Sometimes I laugh because I'll see a post or, somebody will put up a meme or what have you, or an article or whatnot. And I laugh and I say, well, I've lived long enough and I've been at this long enough now to see my work, my early work, now echoed by the next generation. And I thought, well, I should start picking out the nursing home now. But that is very gratifying because it shows that people are taking back their power. And that's something we have not had enough of in endometriosis. It's not a perfect system. You're still going to hit those barriers to care. There's still going to be GoFundMes. There's still going to be people selling their homes, which horrifies me. I say it horrifies me, but I also hit my 401k, so I get it. I understand it. We're still going to see that until the institutional changes are made. I don't know when that will come, but the more people who are vocal and the pushback continues, I think we'll see it. I think we'll see it in this lifetime. I hope so.
Really? Really, really hope so. But you're right. That shift has been encouraging, and yeah, when you see the echoes of your own work coming back, you're like, okay, we're not doing too badly.
Tenfold. I don't know if it was maybe it was Dan Martin who told me. Could have been Dan Martin. You know, he said they say it takes about 30 years for stuff to start taking hold, and I thought, well, I can't wait that long, but it's been 30 years. So he was right.
But yeah, it's yeah, when you do see echoes of that coming back, it is really good. And it shows that even getting into the subconscious of people, we are making a difference. But equal to that, like, and just when we bring up some well-known doctors' names there, like, there's been a lot of backlash against advocacy, and a lot of it aimed at specific individuals, including myself and yourself, and a lot of it aimed at the community as a whole. And without getting into a whole podcast episode on that alone, because we could be here for another week, what sort of guidance would you give in terms of advocates taking on that information? Do we react, and do we feed into this need for attention, or do we continue and hold our heads up high and continue with the good fight? Is there a better way for us to handle this as a community?
Well, first of all, I mean, I think, we are professionals. We work in our own respective healthcare industries and positions. So there's a level of maturity and professionalism and a level of ethics that, we have to adhere to no matter what, no matter how many stones are thrown at us, no matter how many, stories are shared and contain misinformation and outright defamatory lies about us. You can't react. There's too much important work that needs to be done. I think a lot of the backlash against advocacy really stems from threatening the status quo, right?
Mhm.
And what I mean by that is it's very easy to sit in the ivory towers, particularly of academia, where they are sort of quasi removed from the day-to-day patients. They're not sitting in the OR with them sobbing and their families sobbing, and they're not in their bellies seeing, oh my God, what exploded in here, how many hours this is going to take to fix. They don't have the skills needed to fix it. So I think there's a certain level for some people to be very removed from that aspect of it. It's very easy to look at a research study or a piece of paper and form opinions and then want to establish entire protocols on the basis of that without considering the human factor. Advocates represent the human factor. Whether or not we work in the profession, hospital, chemistry, advocacy, private practice, whether you work in the profession or not, or you are sort of an adjacent advocate who is telling your story, which is equally as important, that is a threat to the status quo, right? I can understand being upset at misinformation that is pushed. I can understand being upset at physician rosters that are pushed. They upset me as well. There's a lot of parts of our community that rightly deserve being upset at. What is not rightly deserved is the stones that are thrown at those standing in the gaps. And it was interesting to me. I'll share a little story without naming names because it's not important. But we know that at a major conference a few years ago, we know that a very, very prominent person stood up in a pharma-sponsored breakfast, by the way, and said patient-led advocacy is very dangerous. That same person, coming full circle, was recently in a situation that I was able to witness, who said, wow, you advocates, you're so effective and professional. What did you think that we were doing? So I found that very humorous. Like, there's a lot of misunderstanding that stems behind a lot of the rancor and the vitriol, to use a term of one of our favorite terms. I think that if people came together at the table and had adult conversations and listened to each other, a lot of that would be mitigated. Unfortunately, it's very easy to see one comment on social media or read one journal article and throw your hands up and react emotionally and react viscerally, because let's face it, this is our life. It's very easy to react. But I think at the end of the day, you have to keep telling yourself there's too much work to be done. Stay the course, continue what we're doing. Somebody somewhere is being helped by this. If it helps connect someone to better care, we cannot stop. Now, that doesn't mean directing everyone to a specific surgery. That doesn't mean directing everyone to PT or directing everyone to a medication or a specific physician or a Facebook group. That means helping the person decide their own journey and helping them get there. And I think that a lot of folks don't understand that that's what we do. At the end of the day, no matter where we're working, in which setting, that's what we do from an advocacy perspective. So there's a lot of misunderstanding. And I think a lot of it could be solved by having a conversation at an adult level. Folks are not willing to do that, and that's okay. So we move on. When they go low, we go high, and we continue our work. That's it. We don't have a choice. Too many lives are at stake.
Absolutely, too many lives at stake. And I think you're right when you say it's personal, and it's very easy to get so disheartened and so angry and so frustrated at the whole thing. And, certainly it's one of those things that when you do find yourself in a situation where you're sitting on a board or a committee or in a meeting with these people who are criticizing advocates, and when they realize the level of professionalism and the level of hard work that goes into advocacy, and the 3:00 responding to emails and the 3:00 responding to people, stressed out of their minds, they don't see that, and then they have their eyes opened. I think that's the only way we can change that. It is, you're right, it's having an adult conversation around it. And I suppose all we can do is hope that, again, we're seen as giving patients information to make a choice. Certainly any of the advocates that I follow and have followed for years have never been dictatorial in their approach. They've never come out and said to me, you must have this particular treatment or you must not have this one. In fact, I don't think I've ever seen that in my time.
We
yeah.
see that a lot, particularly recently, and it's ridiculous. Again, I look to social media because it's so easy to see a curated snippet of something and form an entire basis of an opinion on that. And, that's problematic because, again, that message spreads like wildfire. But the truth of the matter is that's really not what's going on. I don't care who you have treatment with or what your treatment is. Just do a treatment that works for you. I don't care what care you get. I just want you to have access to care. And I think folks don't understand that. And that may be because a lot of us have had a particular course of therapies that did work, and they don't work for everybody. And that's the nature of the beast in terms of endometriosis itself. But that level of misunderstanding, this notion that we're just sort of running willy-nilly around the internet, just screaming surgery and excision, or, Dr. Joe and Dr. Jane, it really, it's aggravating because it diminishes the true basis of what we do, how we do it, and the fact that we are equally as educated and more dedicated to ongoing education, perhaps than some of our peers or colleagues. And I think any time that anyone wants to malign an advocate, I think they should get out of the way of the people who are doing the work.
That's something I always say, isn't it? When you want something, don't ask a very busy woman, and you can see that in this whole sort of community as well, to ask a busy advocate and they'll take on more work. So in terms of any of our doctors, surgeons, caregivers that are out there who are wanting to make a difference, who really do want to change how they approach endometriosis, how they look after their patients, what would your advice be? Where would they start? What would be the next step? If you're a doctor sitting in Ireland thinking, how can I best help patients?
Well, you can start by listening to them. Okay, and you can start by listening to understand, not just reply. You can start by educating yourself, becoming involved. Once you start to immerse yourself in this disease and the education and the lived experiences of it, you start to see not everybody has the same story. They're not going to present the same way. They're not going to respond to the same treatments. But there is a core. There is a core to it. And if you can really be compassionate and want to do better for your patients, I think that's a win. That's not to say that you can do a 9-hour surgery and a bowel resection. I'm not saying that. But if you're compassionate enough to care about your patient and say, I want to help you get care, whatever that care looks like, that's half the battle. I would say, if you're a researcher, again, it harkens back to that patient aspect. Are you involving patients from a performative perspective, or are you really caring what they say? Are you really conducting your research in a way that's translational and meaningful to the patients of here and now? Or is it more esoteric that may or may not benefit, our children 10, 20 years from now? I think you have to really think about what patient priorities are in terms of not just your care strategies, but your research strategies, ways that you're educating yourself about the disease. And if you're an advocate, it's my advice is the same every time. It doesn't matter if you hold a professional station in life or if you are simply looking to tell your story. I think your voice matters. All voices, even if I disagree with them, your voice matters. You should be able to tell your story, whatever that looks like to you. And I think the more conversation we have about endometriosis on an international level, cross-talking across all interdisciplinary, all patient levels, all physician levels, that's where the answers will come. And it can't be just the ones you cherry picked for your conference, or, who your industry sponsor cherry picked. It has to be people from all walks of life, all backgrounds, even all inherent biases, right? Because how are we going to correct those biases if we don't confront them? So coming together in working groups and other types of scenarios and situations, that's where the dialogues happen. People will often say, well, I'm not going to work with them. Well, I don't have that luxury. I have to work with them, and I feel compelled to work with them because if we're going to fix it, it has to come from the inside, and we have to be part of the solution, not the problem, right? And I think that's just how it's going to have to be. Crack open a journal article, talk to your patients, host a support group, get involved, as if you're a physician or a caregiver, a practitioner. If you're a caregiver, believe your loved ones, listen to what they're saying. I still, probably now 32 years later, someone told me, why don't you just go take a shower? No, I have a ruptured endometrioma. I need to be in the hospital. I still remember that. Commentary like that is not helpful. You need to find out what your loved one needs, what's going to help them. Sometimes it's just being there. All of that matters. It's at the end of the day, it's about supporting patients in any way that they need. So it's hard. We don't have a magic bullet. We don't have a magic, strategy that nobody gives us a manual and says, this is what you need to say, when and how. These are the treatments you need to have, when and how. We don't get that. So it has to really be organic and work in your life.
It's one of those diseases too that, communication can make or break how you're feeling on a day. And communicating your own symptoms to a loved one and communicating that then in a healthcare setting and communicating that as an advocate can become very difficult. But also that communication you receive back from that, and you sort of grimacing there when you had said about the comment about the shower, and we've all been on the receiving end of those helpful comments, which are not helpful at all. But then equally, it's the same thing. If wearing orange knickers makes you feel better and reduces the pain, right, go for it. But there are times when we have to put the hand up and say, yeah, actually, no, enough's enough. We need help. And gluten-free. Yeah.
Exactly.
Yeah, it's yeah, the unsolicited health advice still keeps coming, doesn't it? Even in 2023. Yeah, there's no end
Part
to
of the
that.
problem, we talk about the dark side of the web, right? That's one of the biggest problems. I mean, I can't tell you. It's just scrolling through, sponsored for you. It's just like, join my course. I will have you, cured in a week, and I'm like, oh my god, people are vulnerable. They're going to
Mhm.
believe that. Um, there's not a lot of honesty or transparency in that sort of section of the web, and it's dangerous. It's
It
dangerous.
is. It's very dangerous because at 3 and 4 in the morning, again, when you're at your absolute wit's end and you're thinking, oh, somebody was promoting a particular device or a particular diet or a particular essential oil or a particular lifestyle, maybe that'll work. I've tried everything else about my wit's end.
Right.
And before you know it, you've the card in and you've it paid for, and your wallet's lighter, but nothing else has happened.
Right.
Yeah, it's like and me, I'm all for the 1% theory, everything that helps,
Right.
but there are some absolute grifters and scammers out there that unfortunately you would spend 24/7 trying to report everybody.
That's
um
not a lot of regulation. It's
mhm,
one thing. The flip side of that is to also have realistic expectations, right? I mean, it's one thing for your surgeon to tell you, for example, I believe you'll have an 85% chance or better of having an improved outcome. That's not the same thing as telling a patient they're going to be cured. And there seems to be a little disconnect between that and reality for some folks. So I think it's really about moderating your own expectations as well and going into it with a really informed consent lens on. But when I see, this chipper smiling face 2, 3 a.m., like, for me, it's like, get rid of your wrinkles, right? I'm like, okay, I'll try that. But then the rational voice in the back of my head says, cut it out. But that's what we see, and that is the dark side, I think, of it. Eating elderberry teas is really not maybe going to shrink your endometrioma, and it's not going to remove your adhesions. You have to really think about it critically and say, and like you, I am a big fan of do whatever you want, including hang upside down or do nothing, if that is your choice. But I think you also have to guard yourself and say, all right, that's probably not going to work. If there's any basis where it's because I didn't get along with my mother as a child, probably your therapy is not for me because I have an actual organic disease. So I think it's really just about being cautious, putting on your thinking cap. If it sounds too good to be true, it probably is. But then also temper your expectations for realism. If a disease process has been at work in your body for 25 years, you're not going to be cured or fixed overnight. This is a journey. There are multiple parts to it. I think that if you try all of the adjuncts and you have some empowerment and some control over it, I think that will help. We hope for everybody to be helped. The reality is not everybody can. And that's where our work continues. We try to continue to make it accessible, but your coaching program is probably not going to help me. And your wrinkle cream probably isn't going to do it.
we're easily swayed at times, but it sort of brings us back to what you were saying earlier, is that we're still stuck in this absolute mire that endometriosis is a disease of periods. It's
Right.
a disease associated with a particular type of woman. It's a particular type of, this, that, and the other. And I think if we replace the word endometriosis with another disease, would we talk about it in the same way? Would we have the same misinformation?
No.
Would we allow, less than, sort of experienced, surgeons or less than experienced clinicians work with us? Like we're we've mentioned this already. We are basement when it comes to healthcare. And I think that's one of the things too, that shift in recognizing that endometriosis is now, a systemic chronic disease. It is not, confined to the gynecological organs. it's probably never going to come out from under gynecology, well, not certainly in my lifetime.
Yeah.
But do you think we will see at some stage an internationally recognized definition, not just of endometriosis, but of what an actual expert endometriosis surgeon or clinician is? Can you see it? Can you ever see an international consensus on that come in?
On the one hand, I am encouraged in thinking yes. On the other hand, knowing the personalities and knowing where all the bodies are buried over the last 3.5 decades, I'm not so sure, because I know that there are differing agendas. Which is not to say that there's some great conspiracy. I don't mean that. There are human beings here. Everybody's bringing their own agenda, their own bias, their own goals, if you will, to the table. So I don't know that you can ever really come to a consensus, because there are so many different schools of thought. You have the imaging followed by hormones followed by hysterectomy crowd. You have the surgical intervention followed by nothing crowd. You have the centers like ours, which are multidisciplinary, which involve excision as the cornerstone, who then refer to different umbrellas and different adjuncts, which in my opinion is the best way to go, because it is a systemic disease. You must address it systemically. You have, the academic ivory towers who continually position it as, the white woman's menstrual disease. I mean, there's all of those factors at play. So who decides, who's a specialist? And I think there may be different aspects of that specialty. There's an expert surgeon, yes. But maybe there's also something which is, sort of a broader endo specialist. I don't know. I think that, the powers that be really need to come together for the greater good of the patient at the end of the day, and stop worrying about what else is going on and who gets to moderate what chair at which conference, and start recognizing that we are losing people. People are taking their own life from pain and just utter despair. There are millions of people who cannot access care. There are millions of others who do access care and now live a lifetime of debt. There are others who did access the care and, all of the recommended therapies haven't worked. There's so many different nuances and aspects of the disease. I think coming together and saying, what is an endo specialist? That helps. We absolutely need to recognize the surgical subspecialty from a fiscal standpoint, because at least here in the USA, that's how our reimbursement will be changed, and that's how access will be increased. But I think from a global perspective, if we start recognizing the centers formally as endo specialists, that's going to help cut down on, these vetted lists, so to speak, which are in fact not vetted, or these patient authored lists, which are great because they had a great experience, so they want them on a list. But what about everybody else who didn't have a great experience? I think it will do away with all of that. And this is not a pipe dream. I mean, there are different disciplines of medicine that have this. There are different accredited boards that do this. So it's not far-fetched. And I think that we could see it. But again, folks have to be open-minded and come together for the greater good of the patient. If they're willing to do that, maybe.
Yeah. Accreditation and bringing standards in can only improve things. But again, people have to be willing, they have to be open-minded, and they do have to have a real enthusiasm for change and process as well too. I suppose, Heather, I'm very conscious of your time, but I just want to wrap up and just, if I was to come to you now, like I did 25 plus years ago, for advice, living in Ireland, there's limited resources as a patient. What advice could you give me in general, and what sort of support would you say that I could access out there? We know there's some very good resources. I've mentioned the Endometriosis Summit in previous episodes. Huge fan of Sally and Dr. Vidali's work. And, we have the Endo Girls blog, and we've got lots of individual advocate accounts as well too. So is there anything that you would like to add there that would be a real gem for patients out there that are struggling at the moment?
Well, the first thing I would do if you came to me like you did 25 or 30 years ago is I would hug you. That would be the first thing that I would do. And I would say, I understand. But no, I mean, we have a lot of really, really solid resources. Um, which are really for example below the belt, right? It's not just a movie, it really truly is tied to a movement. It was Shannon Cohn that got Department of Defense funding. I don't know if people know that. It was Shannon and her movie and her advisors and her panelists and so forth that got it before Congress. There's a lot of different things going on there. There's school education kits, which sort of follow, not exactly, but sort of follow the path of Deborah Bush, who was the first one to implement school kits, right? Doing really important work. And I know people love to throw stones. If they knew the kind of work and the kind of sacrifice that went in for altruistic means, and nobody's benefiting in any way from it, I think they would have a second thought about it and be more supportive. But the movie is fantastic. The movement behind the movie is phenomenal. Of course, as you said, Endo Summit. You personally, you are my go-to. Endo Girls blog. I know I'm going to miss a million, so I don't want to name any. But there are some really, really good, strong, solid, ethical, moral groups out there. I actually have a list that I can send anybody who's listening to this and is interested. I have like 4 or 5 pages of links, just of groups in every corner of the world, from Endo Black here in the US, to folks in the Caribbean that are doing such really good work. Books, articles, movies. There are a lot of different things in the works by a lot of different people. The common thread that brought us all together, I know folks love to speculate, but the reality is the common thread that brought us together was trying to make a difference for other people after we suffered and struggled, and some of us are still struggling. You know, join us. We're here. We want to ensure a seat at the table. We gain nothing other than the ability to say, thank God you're not suffering like we did. We're here. We're here. There are always room, there's always room for others to join the movement, to tell their story, to bring their ideas, things that they're doing. I think, in terms of, like you said, meeting people where they are is critically important. If you are living in a region that you literally have no access, even if you have the means, you can't access care, you have to be able to get support and have treatment to the best that you can, whatever it looks like. For some folks, that's going to be medication. For others, it's going to be more holistic or complementary type of adjuncts. For some, it's going to be all of the above. I think finding a physician partner who is compassionate and caring, even if they lack, sort of that technical skill or that specialty skill. Compassion goes a very, very long way. If you're a high supporter of your patient and you want to try to help get them the best care that is possible that they can get, that can change somebody's life. And I think that we need to stop overlooking the pain component. Chronic pain is a killer, literally and figuratively. I think helping people manage their pain, manage their GI symptoms, their painful sex, their bladder symptoms, their collapsing lung every month, all of these things, the leg drop or dragging their leg because they have such terrible sciatic endo. These are real things, and so many, many people are struggling and suffering with them. We've got to see more help for them. And I think partnering with a physician who cares is the first step. If you have the means to go to that quote unquote, as we term it, endo specialist, that's phenomenal, but too many people don't, unfortunately. And that's where that physician education comes in. Educating the GPs, educating the GIs, educating the Euros, pain management, teachers at school. I mean, you name it, everyone can benefit from endometriosis education, and ultimately it educates the patient and benefits the patient. So it takes a village. It's a team sport. We are here. We are happy to help. We've done this for a long time. We're going to keep doing it no matter how many stones you throw at us, because somebody somewhere right now is struggling in silence or screaming to be heard. And as a human, I cannot watch suffering. So
100%. 100%. It is knowing that if only one person hears this and it makes them think differently about how they're feeling, or it makes them think differently about how they're going to approach their care, we've done our jobs. And certainly that's the way I started out after watching you over so many years and the impact that you had. It was always a case if I can help one person. And we've had this conversation so many times before that there are days when you are banging your head off the desk and you are drained and frustrated and angry. And then you get that one message in to say, oh, I went to the GP today and I spoke up for myself, and the GP has listened to what I want, and they're going to refer me, or they're going to give me this treatment, or I've got a referral to pelvic physio. And you're just like,
finally,
okay, so big deep breath. We can do this. We can keep doing it.
well, first of all,
And
I want
again,
to point out that the fact that you've changed an entire landscape of care in an entire country for you, on your back, those efforts were made. So give yourself a little bit of a pat right now, because you have saved lives, literally and figuratively, not just in Ireland, but really for everybody whose life you've touched, you've improved. So give yourself a big fat pat on the back for that, please. You know, giving credit where credit is due. I mean, but you're right. It's, you know, the burnout is real. I probably quit 12, 14 times a day, every day, because there is disappointment, and then there is outright abuse. And I don't think that people know what we put up with on a literal level. You know, other folks get to go home. This is our lives. And that's very difficult. But then you're right. You know, I got a message this morning from somebody who had been a patient a very long time ago. I'm talking 15 years ago. They had a child. That was their choice. They had a child. The child is, you know, now going off to college, and, you know, all of these things. And they themselves were able to realize their career goals. I don't want to give too much away in any way and try to identify them, but things that make a difference, right? And you get those messages and you're like, okay, I still have a little left in me.
It rekindles it a wee bit for another while until we get the next frustrating head desk banging. Oh, yeah. Oh, Heather, it's been fantastic chatting with you. And, you know, it's like I always say to people, I learned from the very best. I was very fortunate that my time came in when the internet was really starting to come into Ireland, and it coincided with me being in college as well. So I really got you guys at the very, very early stages and got the best out of you and learned and grew with you as time went. So and again, thank you for all your hard work.
Together, you know, I mean, I think about that 3 or 4 a.m. Nancy Peterson rolling into a chat room to, you know, secondary organizations being formed, and from that, you know, advisorships being formed. And I mean, of course, you know, they're not all together anymore, which is fortunate or unfortunate, however you look at it. People evolve, people grow and move on. But you know, that room is the origins of much, much bigger groups today. And that's kind of exciting to see. You know, I think it's not perfect. We don't have a perfect landscape by any stretch of imagination, but we all came up together, and we all learned from each other. And I am grateful.
Absolutely. And little acorns into big oaks, you know, and all we can do is just hope that, you know, the acorns coming behind us will impart the same knowledge, you know. Heather, again, thank you so much for joining me. You know, a lot of the, especially my Irish listeners, will have heard you speak before and are so appreciative of your time, because we know you're incredibly busy as a board certified patient advocate, and your work with the CEC and everything else that you do behind the scenes that, you know, like even I don't know the full story of it. So I am truly appreciative of your time. And I hope again we'll get a chance to catch up. For anybody who doesn't know the CEC's website, I'm going to link it all in the show notes, and some information then as well to where you'll be able to contact the CEC and contact Heather for any information that you need there as well too.
Absolutely.
So thank you very much for listening to DEARG. This has been a brilliant episode, and I look forward to chatting to you all again. Thank you.
Thank you.